Hello, everyone. This is Dr. Carrie Bedient of the Fertility Center of Las Vegas, back with my darling co-host, Dr. Abby Eblen from Nashville Fertility Center,
Hey, everybody.
and Dr. Susan Hudson from Texas Fertility Center.
Hello.
How you guys doing?
We're
Doing
good.
great. Glad to talk to you guys. It's been a little while since we've talked.
I know it's been a couple of weeks, and I'm like, every time I hit a Sunday afternoon and we're not recording, I'm like, what am I missing? Something's not right. I'm not where I should be. And where is Susan and Abby?
I know, it's almost been 3 years since we've been doing this. So you're right. It's kind of gotten ingrained. It's what we do on Sunday afternoons.
It
After our
is.
beds.
It's exciting. I think we just published our 150th episode at the time that we're recording this one. So
Yeah.
that's pretty cool stuff.
That's exciting.
Who knew?
Yeah, that tracks with 3 years. Because I
Yeah.
don't think we've missed a week in the entire 3 years.
No.
So
Can you believe we've done 150 episodes on fertility? That is just so exciting.
Mind-boggling. Yes, it is. I mean, I never would have dreamed when we started out that we would be at this point. I thought getting 12 episodes a year would be enough. Little did I know.
Yeah, well, that's what we were originally planning. Like,
Yeah.
okay, we'll do one, once a month and blah, blah, blah. And here we are. What's new? Anything new in life? Anything exciting? Or just same old, same old?
My doggie got very, very sick yesterday, and it was
What
very
happened?
scary.
What happened? Yeah.
She that morning she had thrown
What
up
kind of dog? What kind of
she's
dog
a
do you
miniature
have?
schnauzer, and she's
Miniature
about 8 years
schnauzer.
old. So, old enough to start getting worried about, health issues and that
Yeah.
kind of thing. But she's been pretty healthy and, things like that. And she had thrown up once in the middle of the night, but it was like dog food and leaves. And I was just like, oh, she had an upset stomach.
Dog food and leaves.
Yeah. I was like, okay.
The usual.
But my husband and I were gone for the day and the kids were at home watching her, and she had thrown up a couple more times, no big deal. But then she started having blood, like frank blood. Yeah.
That's not good.
It was not good. And so we ended up having to do the, middle of the night pet ER thing, which I always hate doing. The first one we called said that it was going to be a wait of 3 to 4 hours. And I'm like, I don't think we called our vet, and our vet was like, if they can get you in quickly, go there. Otherwise start calling around. And I'm like, I don't think 3 to 4 hours is the definition of quickly. No. So we found another one
terms anyway.
Yeah. So we found another one that was like 45 minutes away that they could have pretty much immediately see her. So that's where we took her. So, we were there until like 1 a.m. and then they, ended up admitting her and getting her IV fluids and antibiotics. She apparently had an intestinal infection. And so it was hemorrhagic gastroenteritis. So she was just bleeding, and she was.
So did they just treat her like symptomatically, support her with fluids and things like that, or I guess there's
fluids and like IV antibiotics and
so it was
bunch of
bacterial,
like vitamins and so bacterial. They had done a little slide and could tell there were like the bacteria were there and everything like that. So. But we had to go pick her up this morning. So we dropped her. So we left at like 1 a.m. and we had to be back by 7 a.m. And again, this place was about 45 minutes away from our house.
So you're not operating on very much sleep at all.
No, I came after we brought her home and got her tucked in, took another nap. So doing okay, but I have a little Coca-Cola by my side for a little extra caffeine and sugar today.
Oh, wow.
But she's doing better, but she has like 6 medicines, and actually my husband's assignment while we're podcasting is to make a spreadsheet so that we can print off because she has 6 medicines, and some of them are 3 times a day, some are 2 times a day, sometimes in the morning, sometimes at night. I'm like, there's no and she's going to be on these for at least a week, and some of them longer. So
were they able to identify the actual bacteria, or that just
not in the middle of the night? So they saw rods, cocci, and spirochetes. So she's on Flagyl essentially.
Hey, we know all about Flagyl.
Don't let her drink any alcohol. Right? No alcohol on Flagyl. Keep the dog away from the champagne.
Doxycycline? Does she on doxycycline too? Or?
No, she got a fluoroquinolone last night, IV. And she's on the Flagyl. And she's on probiotics and a whole bunch of other stuff, but she's resting comfortably. She is much happier than she was yesterday. So, but we have we have her all kind of bundled up in her favorite little place. And so, but she's on the mend, but that was scary. The last time we took a pet to one of those late night emergency things, that pet got diagnosed with an 8-centimeter tumor, and it was not good. So
we had an experience like that too a few years ago. So,
but
well, good. Well, I'm glad she's doing well.
I'm glad she's good.
She'll pull through and do okay.
My
That's
puppy
great.
baby.
Happy ending.
Yes.
Yeah. Do you have a question for us today?
I do. So this question is, hi, my husband and I started our fertility journey 2 months ago, and I've been listening to your podcast for a while now to make sure I go to our appointments with the right questions. I have hypothyroidism and been on medication for 10 years. I would like to get more information about how your thyroid impacts fertility. They increased my dose as they said my levels were too high for pregnancy. Additionally, through Sono, they saw I have uterine polyps. I don't see much about this online. How are uterine polyps impacting fertility? I'm scheduled to get them removed before trying for IUI. Thanks so much for your help. These are 2 great questions that affect a lot of people.
A lot of people.
Yeah.
I think probably each of us had the uterine polyp discussion. I know I have it once a week at least. I had one Friday. And just to kind of jump to that part of it, we think that uterine polyps are kind of create inflammation, a sterile inflammatory reaction inside the uterus. You know, normally the uterus, the 2 side walls of the uterus sit together. And so if there's anything in there, it just causes irritation as it kind of rubs together. The 2 side walls rub together. It's kind of hard to know with polyps, though, which ones are clinically significant, if they all are, if there's a certain size. I think most of us in the field of infertility, you know, as one of you guys have said before, it's kind of shades of gray. Sometimes it's not just one big thing that causes infertility. It's a lot of little things. And so this is one of the little things that we think that we could have a positive impact on by going in surgically and removing those to sort of decrease that sterile inflammatory reaction. It's kind of like I tell patients, you know, IUDs are a birth control method that a lot of women use. And the primary way that IUDs impact or cause infertility, keep people from getting pregnant, is just by sitting there. It's a T-shaped structure, real small, sitting inside the uterus. It causes friction and irritation. And of course, some of them do also have hormones associated with them, but it's really the friction and irritation that really prevent embryos from implanting. So that's kind of the biologic plausibility, the reason why we think it's important to get rid of those when you're trying to get pregnant.
I agree with all of that. It's one of those, you know, I think the shades of gray was one of my statements.
Yeah, I think it was too.
In fertility, you know, oftentimes.
And I've used that several times, Susan, since you said that to some of my patients.
It's a little of this, it's a little of that, and creating a beautiful, healthy environment for the embryo to have a great home for the, you know, next 9 months. It is going to have an impact. I don't usually think that polyps are the entire explanation, but I definitely have seen it have a huge impact. And then kind of going on to the thyroid thing. So if you have well-controlled thyroid disorder, whether it's hypothyroidism or hyperthyroidism. So when you were talking, our listener, that your levels were too high. So really it was your TSH level that was too high, showing that your thyroid is actually underactive. And so if you're on thyroid replacement therapy, most REs are going to want you to have a TSH level less than 2.0 going into pregnancy. And thyroid is the major metabolism hormone in your body, and it not only controls lots of things that are going on for you, but it also helps with healthy baby brain development and different things like that. So well-controlled hypothyroidism really shouldn't have a negative impact on your fertility. I know, especially recently, I've seen, have y'all had this where people come in and it's like they've been diagnosed with Hashimoto's, and it's like, oh no, I'm never going to get pregnant because I have Hashimoto's. And I'm like,
it's treatable.
No, I'm like, we control it. And then you're going to be at the same success rate as other people who have naturally, you know, normal thyroid levels. Do y'all see that in your practices now?
I have a lot of people who are so anxious about their thyroid, and it's important. I mean, if it's really dysregulated, then that can be related to very irregular menstrual cycles, either too little or too much, depending on which direction. It can be related with miscarriages, but for the most part, like, thyroids are fairly straightforward to manage. You get on meds and it regulates, and away you go. And so I don't entirely understand the drama around that, other than I do very much understand once your thyroid goes awry, you're usually on those medications for life. And so I very much understand that trauma, but
I think part of it is just with anything, and I think this is true. I see PCOS patients, the same sort of thing. Once you've been given a label and you've been told you have this condition, all of a sudden it just, you probably read about it on the internet, you hear all these awful stories, and you just think, oh my gosh. But like Carrie said, most of the time, thyroid is really easily manageable. Most people, I mean, it's a rare person that doesn't get managed pretty quickly.
Mm-hmm. Yeah, absolutely.
All right. So our topic today is very much inspired by a listener question, and it's what happens after the retrieval, because we spend an awful lot of time focusing on what happens before the retrieval and during the retrieval and leading up to it and all of those things. But this listener is wanting to know, can we please do an episode on what to expect in the IVF journey after the retrieval procedure? So first part of this question is, how long does it take to go back to normal? So let's talk about what happens once you leave the procedure room. So everything is gone just fine, and let's say you've had kind of an average number of follicles, not a huge number, not several dozen, not two, but what happens once you get wheeled out of that room?
Well, you start waking up. Most of us use some form of what we call conscious sedation. So you're breathing on your own, but you shouldn't really remember anything really from your procedure. So you'll start kind of waking up. You may be a little groggy and this type of thing. Different people wake up from anesthesia differently, but the general process is the same. And usually that takes about 15 to 30 minutes for you to kind of be relatively with it, where you're going to remember all parts of the conversation. You may be kind of achy and crampy, and that's normal. That's very normal. If a lot of times the anesthesiologist may have given you some medicine through your IV to help with the pain already. But if you're ever having any significant pain, let your doctor or nurses know, because there's other things that we can give you to help kind of get that pain under control, because we want you feeling pretty good by the time you're leaving. And then we're also gonna, before you leave, we generally have you take a few drinks of something, or a little snack of some crackers or graham crackers or something like that, just to make sure you're tolerating things orally. But most people tolerate the actual procedure pretty well and can leave within probably 30 minutes to an hour of the actual retrieval.
Yeah, and one other thing we always do, and I'm sure you guys do it too, is we like for people to get up and empty their bladder. It's rare, but it happens. Sometimes procedures, and it doesn't have to be IVF. In fact, I have a urologist that said he had a boy who had a urologic or had a wisdom teeth removed. That's what it was, and couldn't pee. So sometimes your body's response to pain, and it's real rare, but the body's response to pain can be constriction of the bladder muscles, and you just can't pee. Your body just won't let it happen.
Another reason for that is that one of the main medicines that our anesthesiologists use is something called propofol. Mm-hmm. And if you happen to be one of those people who takes more propofol than the average person, which you're not going to know unless you've, been under anesthesia before and somebody mentioned, wow, you took a lot of medicine, that propofol actually can cause urinary retention at high dosages. And so those are the people who are going to have the highest risk of not being able to urinate on their own. But the good thing is, even if you can't urinate on your own, there's things that we can help you do until your bladder kind of wakes up and your body filters out all that medication.
Yeah. So sometimes, even just sometimes a little coaxing, like you turn on the water when somebody's in the bathroom, sometimes that tricks the bladder into working. And sometimes we even have to empty the bladder for the first time. And then after that, the bladder works. It's rare that somebody can't pee but after they leave. And if that's the case, it always comes back. Knock on wood, I've had probably, not just from IVF, but just from surgery in general, 4 or 5 people over the years that have had that problem, and everybody gets really panicked, but it always works again. Just your bladder just kind of goes on strike sometimes, but that's rare for that to happen.
So what post-op instructions do you give your patients for that day when they've gone through their procedure and they're ready to walk out the door, because most of the time you actually can walk out the door. You're not necessarily running out the door, and you're not necessarily walking in a straight line out the door, but you can walk on your own steam. So what do you guys tell your patients as they're walking out the door for the rest of the day?
Just kind of, take it easy. No alcohol. I have definitely had patients who didn't listen to that, and they inevitably come back and they're like, you were right about that. Anesthesia and alcohol don't work well together. Don't do anything strenuous, no major, decision making, no major, projects or things like that, but just kind of bum out and take care of yourself that day.
So my set of instructions has expanded over the years based on what people have actually done after retrievals that they have come back and told us about. So my standard set of instructions is no drinking, no going down the strip, no gambling, no dancing on tables, no major life decisions.
Those are the Las Vegas
No
post-op
sex.
instructions. Ours would be no two-stepping down on Broadway at the Hard Rock Cafe or anything.
No unattended online shopping. Disable your automatic credit card fill-in thing. We've had people come back to us really mad that we didn't tell them not to do shopping. Yeah. And no puppies.
No purchasing puppies?
No purchasing puppies.
Okay.
Yeah.
There's a story there, I think, but we won't go there.
All right. So essentially the rest of that day is, chill out, get full reign of the remote control. I am happy to give people instructions. Oh, I'm really sorry. You can't cook, you can't do laundry, you can't vacuum, you can't clean, you can't do any of that.
Most people like those. Most people like those instructions though.
Yeah, they really like. Most people like, you mean until I get my next period, right? And I'm like, absolutely.
Yeah, sure. That's what we mean.
So what do you expect after? So how long does it really take the female body to go back towards normal, back to where she's feeling like 95% of herself?
Let me add in one thing on a personal note. Having done an IVF egg retrieval myself, and Susan has done one too, and we've talked about this before. I don't know if she had the same experience as me, but having been a physician and done several egg retrievals long before I ever had mine, the thing that surprised me the most was how much it hurt. I mean, it felt like, and by hurt, I don't mean like severe acute pain, but it felt like I had done about 1,000 sit-ups. My abdomen just felt really sore for about 24 hours. But then it's kind of almost like I snapped my fingers, and all of a sudden I was fine. But for about 24 hours, and it was probably irritation from the blood and the fluids that really caused me to be real uncomfortable. And I even took some narcotics because it was so uncomfortable. But I don't know if did you have that same experience, Susan? Do you remember how you felt?
So funny you mention it. It's the things you block out until somebody starts talking about something like this, because as I had mentioned in a previous episode, I had essentially gone across the country to do my IVF cycle. And so we did egg retrieval, and then we were essentially trying to get to the airport.
Oh, wow.
Ooh.
After egg retrieval.
So would that be something in your post-op instructions you wouldn't recommend going to the airport?
Well, I mean, I understand, like, life is life. And, I think if you can wait a day to fly out, it's nice. I remember being this is what I'm trying to, like, I'm flashing back. I remember being in the taxi and with my husband and like laying down on his lap because I was like cramping and moderately uncomfortable. It wasn't terrible,
Yeah, it wasn't terrible.
The next day I was fine because we actually got stuck in a snowstorm. I mean, it was like, the constellation of all good events happening. But I do remember, because I remember being in the taxi and like kind of laying down, being like, oh, I don't feel good. And, taxi drivers, they sometimes are a little, hit the bumps and that type of thing. So it's normal to be achy and crampy. Okay.
Yeah,
and as somebody, I had diminished ovarian reserve. So I didn't have that many follicles. And so I was actually kind of surprised at how achy and crampy I was.
I was definitely surprised.
It wasn't intolerable. And if I would have been at home, I probably wouldn't have even like batted an eye over it. But the fact that I was, in somewhere I was unfamiliar with, and we were traveling in areas, and obviously there was a snowstorm coming in, all those things added up kind of probably made it a little more stressful.
Yeah. So, I mean, it's normal to have a pretty significant amount of pain short term, but if it's real severe, you need to call your doctor because,
Right.
there can be complications with the procedure, but those are rare. As far as the longer term complications and or not complications, but how long does it really take your body to get back down to normal? Probably by your next period. Usually your estrogen level has gone back down to normal. Your body kind of has a way of resetting. Sometimes you can have leftover cyst on your ovaries. And, remember, technically every egg comes out of a cyst. So it's normal that, if you've had, instead of having one on both your ovaries, you have, 5 on each ovary. It just takes a while for your body to rebound and get back down to normal again. And so because of the size of those ovaries, that's the reason why we really want you to limit your activity, for a little bit to prevent the ovary from having problems from that, like torsion.
So actual time frame, most people are going to, Abby mentioned that first period. That first period actually comes faster than most people expect. So
yeah, that's true.
That period usually comes within about 7 days of egg retrieval is what I would say would be average. Some people a little less, some people a little bit more. But I would say on average 7 days. And the fact that you're having your period is showing that you've made a lot of those hormonal changes to get back to baseline. And as Abby said, it's normal to still maybe have some residual cysts from your ovaries kind of shrinking back up. That takes time. Just like everything else, it took you a week and a half for those follicles to get big. It's going to take a few weeks for those follicles to get small too. But fortunately, depending on what your path is from there, they're usually not secreting a whole lot of hormones, which makes them relatively inconsequential.
I would say that some of the post-op things that show up in the days after, a lot of women are constipated. Sometimes that's from the procedure and from fluid in the belly. Sometimes it's just from the hormonal changes because your progesterone goes really high, and progesterone is the culprit in pregnancy that leads to constipation. And so I always tell people this: the second you notice a hint of, hey, I'm slower than usual, manage it aggressively, whether it's stool softeners, Miralax, prunes, whatever works for you. Lots of fluids always. Make sure you're paying attention to that because it can make your life uncomfortable. I also tell people sleep upright and put some pillows behind them, sleep kind of in a recliner position because there's always going to be at least a little bit of fluid in your belly. And if you can keep it down low, that means that at least it's just aggravating that area and is not drifting upwards to irritate under your diaphragm and your shoulders and things like that. So none of that will cause physical harm, but it can make your life miserable. And if we can avoid unnecessary misery, let's avoid unnecessary misery. All right. So what does the timing typically look like between egg retrieval and FET? So we already talked about how before you can do a frozen embryo transfer, you for sure have to get your period. So that right there is roughly, a week or two, depending on if you're the early or the later end of getting your cycle. What happens next? And how long does it take to happen? And is there anything, that's the other part of this question, is there anything you need to do testing wise before your FET?
I think this is great because I bet we all have some different answers for what happens at this point.
Yeah, so that was a multi-part question, Carrie, and I can't remember all the parts probably, but when you talked about timing, the way I've started talking to couples about it is it's about a 3.5 month process, start to finish. The first half of it, the first 6 or 7 weeks is to get the eggs, get the sperm, create the embryos, do the genetic testing if you're going to do that. And then the second 6 weeks is basically to prepare for the FET. The first part, ovaries are stimulated, you're bloated. It's a lot more labor intensive on your part. Second 6 weeks is a little more chill. I mean, basically you start estrogen in some form and you're on it for a few weeks. Then we do your transfer and then we wait 2 weeks later to find out whether or not you're pregnant. So it's kind of roughly 3 months, give or take a little bit. First half is preparation to make the embryos. Second part is preparation to do the embryo transfer.
So to kind of describe what we do, so for you to get your PGT or the chromosome testing results that a lot of our patients do, that is not actually a very quick turnaround time. So it usually often takes a couple of weeks to get those results back. And so what we do in my practice is most people, unless they have a contraindication or something like that, when they start their period, we get them started on birth control pills to keep get things nice and suppressed and kind of put us in limbo while we're waiting on those results. So instead of going straight into an FET, not knowing what the PGTA testing results are and having to cancel the cycle, we'll get you on those birth control pills and kind of go from there. If you have not already had a uterine evaluation, like a saline ultrasound, sometimes you may have that done during that time period. Oftentimes with my patients, if we diagnose a polyp during a saline ultrasound right before we're about to start stimulation, we'll do the polypectomy in between retrieval and transfer so that the uterus is nice and perfect as we put in that embryo. For those of us who do believe in ERAs, depending on depending on your how many embryos you get, if you've had failed cycles in the past, different things like that, that can sometimes happen. And then whenever we have our results, then we prepare the lining of the uterus, kind of like Abby mentioned, and I'm sure we'll go into that in more detail in a few minutes.
So for us, timeline is fairly similar. I agree with the roughly 6 weeks to get all the embryo taken care of, and then another 6 weeks to get transfer and pregnancy test results back. And so we usually will do a hysteroscopy in between those, getting the eggs out and starting the transfer. It allows us to catch any last minute polyps that were subtle and not seen on saline ultrasound. It allows us to evaluate for endometritis and do a little bit more in-depth testing. So all of that is what happens in the interim, as well as one of the most important things, which is letting the body's physiology return to its baseline. Because if you go straight in, there's actually been some studies done that show that if you go immediately from a big stim into transfer, your success rates aren't quite as good. And so we want to let everything settle down. And it doesn't take very long. It's just a couple of weeks. And we get this other stuff done in the meantime. Sometimes people have other testing that needs to be re-upped. So thyroid, A1Cs, those things are probably the most common. Sometimes making sure that you're not particularly anemic, that type of stuff. We'll check that. But usually it's just the uterine evaluation. And then we start in on the transfer protocol. The next half of this question is, what type of meds and injections are recommended to prepare the body for the optimal transfer?
I think there's tweaks, and I think it'll be interesting to see what the three of us say, but the basic process is estrogen. If you think of the embryo as the seed and the endometrium as the soil, we're trying to grow the soil and make it a better place for an embryo to implant. And there's different types, different ways you can deliver estrogen. I prefer patches, but I've also done shots, I've done pills, I've done vaginal estrogen. There's a lot of delivery systems. And essentially the basic idea is we want to give you estrogen for enough time so that it grows your endometrium. Because really the only way we have to the only metric we really have to look at is how thick your endometrium is and how it looks. So tri-layer is what we shoot for, is 3 lines kind of that we see in your endometrium. And so generally, for most people, you're on estrogen of some form for about 3 weeks. We look at your lining before, we look at your lining after. You come in, and that's sort of the moment of truth. What does your lining look like? Are you ready to go to transfer? And so after that, that's when, if we feel like you are ready to go to transfer, then that's ultimately when we start you on intramuscular progesterone. And you stay on that ultimately for about 8 weeks. If you conceive, you stay on it usually about 5.5. And again, Carrie and Susan may differ a little bit, but essentially about 5.5 days you're on it prior to your transfer. The key window is you need to be exposed to progesterone, we believe, for about 104 to 144 hours. And we, in our practice, try and hit right in the middle if you've not had some other test like an ERA biopsy that tells us something different.
So the way that we prepare our linings for transfer, generally we use oral estrogen. I've used vaginal estrogen in the past. I've used patches and injections if somebody's been resistant, but kind of oral estrogen is where we start. After you're on the estrogen for about 2 weeks, we do another blood test and ultrasound, make sure everything looks good, really focusing again on the shape and structure of the endometrium. But we also pay attention to that progesterone level because that progesterone level can show us some women will go and recruit a follicle and ovulate through the estrogen. Most people do not. And if that happens, then unfortunately, the best thing to do is cancel that cycle, because progesterone opens and closes the window of opportunity of implantation. And if we don't know when that window was open, we could just be tossing that little embryo in a very bad environment. And you just worked really hard to create that embryo. And as frustrating as it is to sometimes have a canceled cycle, it's important, because we want to make the best of every embryo transfer we have. And if you are one of those people who that happens, there's other tricks in our bag. I think most of us try to kind of do the least invasive, but the most appropriate. And so when that happens for one of my patients, I generally do like what we call a OCP Lupron overlap, where we have you on birth control pills for a few weeks, and then we add in some injections of Lupron. It really helps keep your ovaries suppressed until that moment that we are going to start the progesterone. It ends up making the embryo transfer prep cycle longer. So it takes longer, and obviously you're taking more injections. So I prefer to limit your injections if we can. And then when it comes to the actual progesterone, I tend to use a combination of vaginal and injectable progesterone in my patients with good results. But it's all variations on the same thing. And then if you've had failures in the past, sometimes we'll do certain types of steroids and antibiotics and in those types of things. And I think everybody has their kind of magic mixture that they use, but they're all similar. It is definitely part of the art of medicine. Just because your doctor may not do something exactly like the one of us, that doesn't mean it's wrong. Okay. Just know there's lots of ways
tweaks to everything.
What about you, Carrie?
So I mean, my favorite protocol is a program cycle using the estrogen and progesterone, like you guys have talked about. And so that is my default. That's what I like the best. That's what I have found to be the most reliable, and how I know what to expect. And so, like you both kind of alluded to, when the preferred cycle doesn't go as planned, most of the time we cancel, stop, and restart. A lot of us will just do the exact same protocol again, or if there's something really specific we know we can address, like premature ovulation, we need to do a Lupron cycle, like you target that. But sometimes it just doesn't look good. And so a lot of the times we will do the exact same thing over again. And I cannot tell you the number of times where I've had a patient look at me going, it didn't work the first time. Why do you expect
you're going to do the second thing?
and it's just like, look, trust me, I've seen, and I especially see this in my gestational carriers who are proven, have had proven pregnancies and have previously been just fine. You can do the exact same thing twice in a row, back to back, and get one cycle that's awful and one cycle that's gorgeous. And so that's why we do it. But failing that, there's a lot of other protocols that we can go to, whether it's a completely natural protocol, whether it's a modified natural protocol using something like letrozole, whether it's gonadotropins. Sometimes we have to use the same meds we use to grow your follicles because your endometrium just doesn't respond to anything else. And then there's the ever popular, what I call voodoo protocols, which are every doc's personal concoction of what they think works the best when nothing else has worked. And there's a whole variety.
AKA the kitchen sink.
AKA the kitchen sink. And all of us have usually at least 2 or 3 variations of the kitchen sink that we try with people when nothing else is working. But yeah, we're really picky. And as much as we know that you are frustrated, that you just want to get to the transfer, we also are trying to take a step back, be super practical, and say, look, it took a huge amount of time, money, stress, effort, and just pure sweat to get here. And so we're not going to let you throw this away when we can see there's an obvious problem. It's one thing when everybody's talking about it together and say, all right, I think this, 6.5 millimeter lining is the best we're going to get. It looks beautiful. Let's give it a try. That's different than, this is your first time. This lining clearly looks like crap.
Yeah.
Just stop and reset.
And when Carrie says looks like crap, kind of what she means, I think, is either the lining's really thin, so that would be a problem. If there's cystic areas in the lining, and I've seen people that have had even one or two and still decided they want to go ahead and they got pregnant. But cystic areas we don't usually like. And sometimes, like you were saying, you can use the same protocol in 2 cycles, and one cycle you see the cyst, the other cycle you don't. Other examples would be like if we see mucus or fluid in your lining, that's really concerning. Sometimes, depending on if it's, this is your first time, I'd probably say, let's just cancel this cycle and move to a different cycle, see if we get a different result. If it's your second time and this fluid still keeps accumulating, then every now and then we'll aspirate that fluid and still try for a transfer. But those are kind of things that can go wrong with your cycle, and we just can't predict those, unfortunately.
And I've had a couple of people recently that had fluid in their uterus, and one of them for sure was actually a person who was coming back for a second baby, and it happened her first time. And it's very interesting when people have fluid in their uterus. A lot of times once we start the progesterone, because realize that starting progesterone, it makes a conformational change in the structure of what the endometrium's doing. And a lot of people will expel all of that fluid. So when I have somebody like that, I oftentimes will have them come in the day or two before we're going to actually do the embryo transfer. So while the embryo is still nice and frozen and safe and sound, we'll repeat the scan. If the fluid's still there, then absolutely cancel. But, a lot of times that stuff will get expelled from the uterus and we can move forward too.
Yeah. All right. Any last minute thoughts of things that just popped into your brain of these are the things that can happen between retrieval and transfer? And one thing that we alluded to that I want to be a little more explicit about is post-retrieval, no sex and no major exercise until your doctor tells you so. So it's not just the day of, it's usually until you get that period. And we're all saying this because at some point, all of us have seen someone who has gone hiking, has had sex, has done whatever, and then had an ovarian torsion or started bleeding. And those are very hard to fix outside of taking out that ovary, which none of us want to do.
Or even more common. Oh, sorry. Go ahead, Carrie. You weren't finished.
Oh, so I was just going to say, so when we tell you to take it easy, we do not mean bedbound, but we also mean, go to the grocery store, sit at your desk job. This is not the time to, to do something wild and crazy, even if it doesn't seem wild and crazy, like, give us the benefit of the doubt.
Well, and I usually tell all of my patients, and I'm surprised the number of patients that plan to go back to work the next day. I'm like, this is a surgery. Your ovaries are huge. And I always say, it's kind of like if you took your size 8 foot and tried to stuff it in a size 5 shoe and walk around all day, your feet would be killing you. Well, your ovary is like the size of an orange or a grapefruit. And you've got 2 of them in there and everything's being pushed in different directions. And your ovaries are probably rubbing up against your abdominal wall. And people sort of think, oh, well, why would I hurt if, my procedure's over with? Well, your ovaries are still really enlarged and really uncomfortable and really irritated from surgery. So I would highly recommend, if you do IVF, take the day off. They're not going to miss you for that one extra day at work. Just take the day off and take it easy. By the 3rd day, you're probably going to feel okay.
Good stuff.
Well, thank you so much to our listeners for joining us and hanging out with us. We're very grateful to have you as always. Be sure to subscribe, leave us a review. We would love to hear from you. We're on Instagram, we're on Facebook, we're on YouTube. So hop on by, leave us a like and a follow, and say hello.
You can also visit us on fertility.suncensored.com to submit specific questions. All questions will be answered on the podcast for the Ask the Doc segment. We'd love to hear episode ideas. So we look forward to hearing from you soon.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right. We'll talk to you soon.
Bye, everybody.
Bye.